Welcome back. So, ladies and gentlemen, joining us now virtually, we'd like to welcome Professor Liu Xiaoyun, Professor, Deputy Director, China Center for Health Development Studies from Peking University in China, who's joining us now to deliver his keynote address on the Chinese healthcare transformation experience. Professor Liu Xiaoyun, welcome.
Okay, thank you. Thank you, Chair, and thank you all colleagues and friends. It's my great pleasure to share the Chinese experience on health system and healthcare transformation. I'm from Peking University, and before the presentation, I just have one piece of news. At Peking University, we are now developing a collaborating center on public health science and technologies between China and ASEAN. So we are looking forward to further collaboration with all of you. My presentation will start with a very brief introduction of the service delivery system in China, but the main talk will focus on this new round of health system reform since the year of 2009, followed by some introduction of performance indicators of the health system. So the Chinese health system, is every system is unique. So as Chinese health system, so we have three parts of the service delivery system. The upper right side is the medical care delivery system with different type of hospitals. So within this group, we have four levels of different hospitals, from national level, provincial level, municipal level, and country or district level. So within this hospital system, we have West medicine hospitals, we have traditional Chinese medicine hospitals. And these hospitals, they belong to the management of the hospital, including the financial and personnel management, belongs to the same level of government, the health bureau of health authority of same level of government. They do not, different levels of hospital do not have direct link between each other. And the upper left side is the public health system, and the Center for Disease Control is the key organization in this area. Again, we have four levels from national to county level, Center for Disease Control. So currently, especially after the COVID-19 pandemic, China's public health system is undergoing significant reform currently. At the bottom is the primary care delivery system. We have urban health delivery system in primary care and rural system. So in rural area, we have township health centers and village clinics. In urban health system, we have community health centers and stations. So one unique characteristic of Chinese primary care system is they deliver both the primary medical care and also the essential public health services. So with that as the background context, I will start to introduce the health system reform since the year of 2009. This is a overall and ambitious reform plan in China. So why did we have this reform? So before the year of 2009, so the inequity in health and healthcare was a big problem in China. So we had, since China is a large country with 1.4 billion population, so some provinces and municipalities like Shanghai and Beijing, the health conditions of the population in this eastern developed area is equivalent to the most developed countries, while in the rural western provinces, the health conditions is somehow to the equivalent to the the least developed countries. So huge disparities between rural and urban, between the high income groups and the lower income groups. So within this, in mind, there is a severe public concern and complaints about the difficulties in access to health services, and also about the affordability of healthcare, because at that time, the majority of the population, especially the rural population, did not have any health insurance coverage to provide financial protection to them. And also the public health system, especially the public hospitals, has had poor performance, which is also the concern from the society and from the policymakers. So based on this situation, China with the national government started overall health system in the year of 2009. But as we all know, a health system is not a one-off event. So in the last 20 years, China has gradually developed different policies to reform the health system. There are a few milestones. The first one, in the year of 2003, China developed a rural health insurance scheme for the new cooperative uh, uh, medical insurance scheme. So this is to cover the 800 million rural residents at that time who did not have any insurance before this policy. And then in the year of 2007, we established another health insurance scheme to cover the urban residents who had not, who did not have any formal jobs. So, and then comes the big overall health system reform in the year of 2009. And then in the 2006 and 16 and 17, China initiated a Healthy China Strategy, 2030 strategy. This is to fulfill the Sustainable Development Goals, the commitment to the SDGs. So the aim of all this reform is to achieve universal health coverage by the year of 2020. And at that time, we met the COVID-19 pandemic. So this is the very brief introduction of the overall uh, transformation experience in the last 20 years, almost 20 years. So the reforms starting from 2009 have some key component. Uh, this five is the key reforms interventions. The first one is the expanding the medical insurance, health insurance system. Second is the develop national essential medicine system. No, Number three is the health care delivery system at primary care level. And number four is the essential package of public health services. And finally is the public hospital reform. So I'm going to introduce the key reform measures in each of the five areas. So in the health insurance system, as I just mentioned, China developed three independent and interconnected health insurance schemes. In the year of 1998, we started a urban employee-based medical insurance scheme to cover the urban residents who had formal jobs, which is still running now. And in the year of 2003, we developed the rural health insurance to cover the rural residents, and in 2007 to cover the urban residents without formal jobs. Later on, the last two schemes merged together to develop a rural and urban residents health insurance scheme. So the changes in the last 10 years also is the first is the expansion of coverage of medical security systems. So up to, by the year of 2011, the three different types of health insurance has almost covered 95% of all residents. It's totally, in terms of the health financing system, it's already a universal health insurance coverage. And then the service coverage the service package is increasing, and also the reimbursement rate increased to uh, so the out-of-pocket payment is about 44% in the year of 2018. And then in the year of 2016, so I mentioned we merged the two uh, uh, rural and urban residents schemes together into one health insurance scheme. And also in the year of 2018, we developed new management structure to establish new ministry level National Health Security Administration in China to manage all the three different type of health insurance schemes. And also reforms also focus on the develop new private payment reforms and supplementary health insurance, commercial health insurance schemes. So this is the first part of the system of the reform. And the second part of the reform is on establishing a national essential medicine system. So the figure shows the proportion of pharmaceutical expenditure in total health expenditure in China. We can see China has a large proportion of pharmaceutical expenditure in total health expenditure. This is not only in China, in many Eastern Asia countries. I suppose in some ASEAN countries also we have a higher pharmaceutical expenditure. Part of the reason is on the health system and a part on the culture issues. So the purpose of this part of the reform is to increase the production and utilization of cost-effective pharmaceuticals and to control the pharmaceutical expenditures. So the reform developed a list of basic pharmaceutical medicine products that are used in primary healthcare providers. And one of the important reform measures is on the zero markup policy. So before the reform, hospitals and primary healthcare facility they can charge 15% profit out of the drug sale. So after this reform, we remove this markup. So this is to reduce the expenditure of the drug from pharmaceutical products. And it's starting in the year of 2019, the national government organized a centralized bidding system to further reduce the price of medical pharmaceutical products. The third part of the reform is to strengthen the healthcare delivery system at primary care level, including investment in the primary care facility system, including the buildings and facilities, development of the human resources for primary healthcare facilities, especially the general practitioners. We developed some training and education program to train general practitioners with some financial incentives and some compulsory rural service conditions for them to serve the rural population. And financial mechanisms, because of the zero markup policy, so the primary care facilities no longer have financial incentive from the drug sales. So as a shift, the government took the main responsibility to finance the primary healthcare facilities. So within this background, the primary care facilities, they do not have strong financial incentives to sell drugs, to provide health services, but at the same time, their incentives, their motivation to provide clinical service are also somehow declining. Number four intervention is to promote equitable access to essential package of public health services. So this is a unique part of the reform. So before the reform, of course, we have in the primary care level, we have the public health services, but this reform starts a standard package of essential public service items This is standard package is the same for urban area, for rural residents, for east and western regions, so that they are the same package. And this government, including the central government, and the local government, combined jointly to allocate a budget to support these essential public health services. The level of funding is on the competition basis from 15 Chinese yuan in the start from the year of 2009 and to 2010 increased to 74 Chinese yuan in 2020 to cover the main categories of basic public health services. So we see this is the package. We see before the reform, the public health service mainly include the traditional child and maternal health care, vaccination, and the infectious disease. And now the new package with increasing funding level, including the health records of all residents, including the health care for the elderly and hypertension type 2 diabetes and the mental illness. So the package of the essential public health services are expanding gradually using this national government and local government funding. Finally, is the public health hospital reform. This is the most difficult part of the reform. So in the public hospital reform, again we started um, the elimination of drug markup policy. So this zero markup policy, starting in the primary care and expanded to the public hospitals in the year of 2017, because with the zero markup, so the hospitals lose their financial revenues. So the reform also includes some price adjustment of the medical services to somehow compensate their loss due to the zero market policy to make the financial balance of the hospitals. We also use some social health insurance schemes, especially the provider payment system, to change the behavior of healthcare providers and also encourage non-government investment in hospital sector. So, in addition to these five area of reforms, China also developed a tiered service delivery system in the format of medical alliances. So this format, medical alliances, combine the primary healthcare system and hospital together, so trying to provide people-centered integrated care to the population, especially in the rural area. So we use within these medical alliances, we use the shared information system. We use some financial incentive from the health insurance schemes, and also use some health workforce strategies to support the medical alliances, encouraging more people to use the primary healthcare services. And during the COVID-19 pandemic, China also started to strengthen the public health system, especially on the Center for Disease Control. In the year of another major issue is in the year of 2016 and 2020, China started the National Strategy on Healthy China 2020. As I said before, this is in response to the SDG commitment. We set up a key health indicator as a goal by 2030. For example, the life expectancy will increase to 79 years old by 2030. So some of the goals and targets are ambitious. For example, the 30% drop of premature mortality from NCD is a big challenge to China. So this healthy strategy China healthy China strategy uh, emphasize a sectoral collaboration, because to achieve this goal, only the health sector cannot achieve this goal. We must have a overall society collaboration, whole of society collaboration to achieve this goal. Okay, so this is the brief introduction on the reform measures during the last 12 years or 13 years. Lots of health information, health system interventions are going on. So next, I will briefly introduce some performance indicators of the health system in China in the last 10 years or 12 years. So first, as a health outcome, so the life expectancy dramatically increased from 35 years old before the 1950s to 78.2 years old last year. So it's a rapid increase of the life expectancy. This is not only due to the health system reform, but also the overall social-economic development is in the last 40 years of the economic reform. And this is the maternal mortality rate by different income levels. We can see there is a rapid decrease of the MMR, maternal mortality rate. And another feature of this change is the disparities between different income levels is narrowed. So also the disparity between rural and urban system is narrowing down so this is a achievement in maternal mortality rate. But the high disease burden of chronic diseases is a big concern in the current Chinese health system. So we see here, this is data from the National Health Service Survey. We have a National Health Service Survey every 5 years, starting from 1993. We see the rapid increase of the prevalence of chronic diseases from 12% to 34% over the last 25 years. Another feature of this change is we see in the beginning of the survey, rural area had a much lower prevalence of chronic disease than the urban city, but now they have a similar level of chronic disease prevalence, meaning the rural population is a high risk population to have the chronic disease conditions. We need to pay more attention to the rural situation. And some figures on the health system 6 building blocks. So, for example, health workers, we can see a rapid increase in the health worker workforce development. I'll give a few examples. First one is the yellow line, which is the nurses. So the Chinese health system, in the Chinese health system, we usually have a shortage of nurses, a lower number of nurses than the doctor, which is the orange line. But in the year of about 2012, we had more nurses than the doctors in the history. This is mainly due to the expanding education program on the nursing workforce. Another type of health worker is on the barefoot doctors. This is a light blue line. Starting in 1970s, we developed to train the barefoot doctors, which is a famous term from China experience. So, but in the mid 1980s, we stopped training the barefoot doctors. They all transformed to village doctors. Over the half century time, we have about 1 million village doctors. They are a type of community health workers. They are very important in providing primary health care in the rural health facilities. Not, although we see a large increase in the health workers, but if we look at the structure of health professionals, we see majority of the increase occurred in the hospital and less in the primary care facilities and even less in the public health facilities, which implies that we need to further strengthen the primary care system and the public health facilities. Education level of the health professionals increased significantly also in the year. We can see from this table briefly, the major problem is in the rural township health centers. We see a majority of them, of the health professionals in the rural primary care settings, had only 3 years medical education, associate degree level. Only 20% of them have university education. So this is the health expenditure. Total health expenditure increased dramatically in the last 20 years. 20 to 30 years. And the proportion of total expenditure to GDP as a proportion to GDP has reached from about 4% of GDP to 6.5% of the GDP. This is largely due to the government financial investment and also the expanding of health insurance schemes. If we look at the structure of the total health expenditure in the year of 2000 and 2001, before the health system reform, the gray part of uh, the figure is the out-of-pocket payment. At that time, the out-of-pocket payment was about 60% of total health expenditure. This is a very high level of financial burden. And due to the expanding of health insurance schemes and this proportion of out-of-pocket payment, a decrease now less than 30%. So the target objective of this indicator is to reach 25% by the year of 2013 in the healthy China strategy. So we were comparing the financial flow, the financial the financial resources goes to the hospital and primary care facilities. Although we see some increase in the primary care funding sources, but there's a much larger increase in the financial resources to the hospital level. So there is a gap is narrowing between the hospital and primary care facilities. In terms of service utilization, we see this is the hospitalized inpatient admission rate in the last 25 years. We see after the year of 2003, there is a sharp increase of hospitalization service use. This is mainly because of the health insurance, especially the rural health insurance, starting in the year of 2003. So the health insurance provides financial protection to the local population and then encourage them to use the health services, especially the inpatient services. So borrowing the experience from the WHO, we also developed an index to evaluate the accessibility and affordability of the health system in the last 10 years. So I'll briefly introduce the key findings of this study. So the left part is the accessibility. If we look at the dark blue line, so increasing, we call this absolute access, which means the access to essential health services has significantly increased even before the reform since the year of 2002. This is mainly due to the health workforce development of the health insurance development. But look at the orange line, we call this relative accessibility, which means the use of primary care as a proportion of total health services. So less people as a proportion of total outpatient service using the primary care level. We need to pay more attention to the primary care system. The right part of the figure is the affordability. Again, we look at two lines. The first is the absolute affordability. Look at the dark blue line. This is mainly measured by the catastrophic health expenditure. So before the reform, we see the declining affordability, which means people have higher financial burden. But after the reform, the index is getting higher, meaning the financial burden is getting better due to the financial incentive. Okay. So, but although we have achieved some achievements in the health system reform, but there are still some major changes and directions in the health system agenda. So, first one is the fragmented health service delivery system. So, although I said we have three different parts of the system, but the integration of the different health service delivery is still a problem. So, we need to develop further develop people-centered integrated care system with a focus on primary health care. Here we need to strengthen digital technologies, including the e-health and telemedicine, which is the topic of this conference, of course. So the second part is on the health financing sustainability, especially after the COVID-19 pandemic. So we need to have more investment on the primary care system and also the public health facilities, and to develop some strategic purchasing capability to have a focus on the public health service and the primary care services. And in the Healthy China Strategy 2030, to achieve the goals, ambitious goals of Healthy China 2030, we need to strengthen the sector collaboration between the National Health Commission and other ministries. And also we need to have some innovation in health governance to achieve these goals. So, uh, briefly, in summary, China has a unique health system, as each and every country does, in terms of the tiered structure, separation of medical and preventive care, and health financing system, and the traditional Chinese medicine. This is some uniqueness of the Chinese health system. The health system reform since the year 2009 had made significant achievement, especially on the health insurance scheme. We now covered almost all the population, urban and rural, to provide the financial protection to them. This is for a big population of 1.4 billion population. This is we believe this is a big achievement to protect Chinese population's health. And finally, the key challenge, we still have some key challenge in terms of fragmentation, high NCD burden, and increasing health expenditure. We need to further develop the health system to further continue the transformation experience to uh, to provide the health to achieve the goal of healthy China 2030. So this is a very brief introduction to Chinese health system transformation experience. I thank you very much. As I said, I look forward to further collaboration with you. This is my contact details. Look forward to further discussion and collaboration with you. Thank you.